This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. Just want to start off by thanking all of you for your support of our Kids Holiday Drive. We are almost finished everything. We've finished the part where we collected money, and I must say we exceeded the goal again this year. Probably we're well over 110 kids we're able to support this year, and still finalizing things, but really appreciate everyone's support. That really makes a big difference for children in need in Fulton County, and it's really a great opportunity for us to give back. So thank you all very much. So this morning we have our own Dr. Rebecca Levit. All of you probably know Rebecca, who came here as a resident as part of our ABIM clinician scientist pathway, and completed her research and cardiology clinical training in the division, and is an assistant professor now. Her work is very translational and really tries to move things from the basic science lab into the clinic. And today she's going to talk about some of those strategies related to cell-based therapies. Rebecca?
Well, thank you, Bob, and I'm really happy to be here. And one thing I've always thought my time at Emory is I've always felt very supported by all the faculty as a fellow and as I've tried to start my own lab. So I appreciate that and hope I can give a summary of what we've been working on. So I do have one disclosure that I'm a founder of a company that our work is going to be discussed at the end of this presentation. Unfortunately, the company's not making any money yet, so I'm not sure if I'm conflicted, but it is there. I won't talk in depth about the burden of cardiovascular disease for this audience. We're well aware. I put some numbers up there, but I was very surprised to read this figure. $1 billion is the indirect and direct costs of cardiovascular disease daily. I did want to maybe add a little bit about myself that you all might not know. And this is related, I think, to why I have been so interested in cardiovascular disease. These are both of my grandfathers who both have cardiovascular disease. My mom's dad actually died from sudden cardiac death at age 69 while helping a neighbor who was having a medical emergency. My other grandfather was a little bit luckier in that he had sudden cardiac death in the parking lot of a hospital and was resuscitated, underwent CABG, and as you can see from these photos, celebrated this year Veterans Day at Miami, and is now at age 93 doing very well. So, sorry for the inappropriateness of this photo. But going forward in the less exciting part of the talk, I'll start off by telling you some work we've done optimizing biocompatible materials to make stem cells work better. Also, I'll talk about some work we've done about how stem cells actually work and how understanding that is very important for cardiovascular disease. And lastly, I'll talk about some translational work that I've done in collaboration with several faculty members, helping develop techniques to translate this into clinical use. It may be no surprise that stem cells are not yet working. There's no guideline that says these patients should be treated with this cell at this time point. And meta-analyses of many types have shown that there's really small, if no, benefit. Subgroup analysis also does not really pinpoint a specific population that may benefit from these cell types. I did want to have one slide about a specific trial which was recently published called the Poseidon Dilated Cardiomyopathy Trial. And the reason I bring it up is because it demonstrates some of the shifts in cardiovascular disease trials of stem cells. The first point is that it's a study of non-ischemic cardiomyopathies. The EFs were low. They wanted people less than 40%. There's some thought that those patients may have more benefit. Ideally, these patients were MRI eligible so that we can more precisely measure improvements or lack thereof. And that's a challenge because, as you know, these patients should all have defibrillators. These patients received 200 million cells, and this trial compared cells from patients, autologous, to allogeneic, which means cells that were derived from some sort of healthy universal donor. And that is also a shift in stem cell research lately. The cost of processing patients' own cells, going through quality control, is very expensive and is actually probably cost prohibitive. It's much cheaper to have a universal cell donor, and so there's shifts towards trying to make that new strategies. With that being said, this small study, I think it had 200 patients, showed maybe a slight trend to more benefit in allogeneic patients who receive cells from allogeneic donors. But this was not powered to detect benefit. And really the more striking results were in sort of the softer endpoints like symptoms and New York Heart Association classification. So one of the shortcomings that I've talked about before is that we don't know how to best deliver these cells. We can do intramyocardial injection with a NOGA catheter or at the time of cardiac surgery, and that's thought to be the best technique at this time. But many studies have been done with intracoronary delivery, even intravenous. One problem is that very few cells remain in the heart by these techniques. Most studies that do cell tracking, like the one I've shown here, show a retention rate around 2% at 1 hour. And that is really way too low to have any physiologic benefit of these cells. So when I was a research fellow here, I worked in Dr. Taylor's lab, and we worked on ways to improve retention of stem cells in the heart and started this technique called encapsulation. This uses biocompatible materials to surround and protect the cells so that they can stay longer, they cannot be washed out, and maybe will be protected from the harsh ischemic environment that you deliver them to. On the left is a single capsule. It's about 200 microns in diameter and contains 200 to 300 cells. We check the viability after encapsulation so that we know that the cells we're implanting are as viable as possible. Working in Bob's lab, we used a technique called luciferase cell tracking. This utilizes that fluorescent protein that fireflies have when you see them, floating around at night. And this only fluoresces or luminesces when the cells are viable. So the animal in the top row with the arrow received cells that were encapsulated. In contrast, the animal at the bottom just had cells delivered by direct injection. And you can see that even at the very earliest time point, there was a fourfold increase in the retention of viable cells in the heart. We went on to show that these cells have, animals treated with the encapsulated cells have reduced scar. And in looking at the mechanism, they had much higher microvasculature in the peri-infarct area, which we thought was part of the mechanism of action. Cells delivered in these capsules cannot exit the capsule, and they cannot directly incorporate into the tissue. So all of the effects they had were through some sort of paracrine mechanism. With that being said, we were very interested in something a little bit more translatable, which is not just ischemia, but what we all strive for, which is reperfusion. Ischemia, during ischemic insults, and this is a patient I had a couple months ago who had chest pain while eating at Taco Mac. So be careful what flavor wings you order there. But you can see she had a complete proximal occlusion of her LAD. During this event, her mitochondria were unable to generate ATP. And if this persists, that red line, all of the cells in that area will essentially die and she will complete the infarct. But because she was lucky enough to be transferred to Emory, she was reperfused with a good result. And during this reperfusion, a lot of things are happening on the molecular level. Oxygen and nutrients are rushing in, mitochondria are rapidly restored to flow, and that actually can cause some problems. Reactive oxygen species are generated, and the innate immune system is now directly accessible to all of that damaged tissue that was stressed out during the ischemia. You can see reperfusion is good. Her infarct was much reduced by the reperfusion, and that is definitely the gold standard. But it wasn't typically reduced as much as you would expect. This reperfusion injury causes some additional form of damage, and that is what we're hoping to mitigate. One thing that we've been very focused on is the innate immune response. Within minutes, thousands, millions of neutrophils and other immune cells rush into the heart, attracted by the damaged cells, the protein, the ATP that's released into the extracellular space. These cells are good in that they clear infections, they clear debris, but they also release a lot of toxic mediators that cause some of this reperfusion damage. This is a neutrophil electron micrograph that shows really all of the armamentarium that it has. It's well known that they can release reactive oxygen species that further damage membranes and proteins. They degranulate, releasing all of these MMPs and other proteolytic compounds into the extracellular tissue. They also release cytokines that attract other neutrophils and other immune cells, setting off sort of a snowball effect to maximize the immune response. The last thing they do is they actually can release all of their DNA in a process called netosis. This DNA is spewed out into the extracellular space, causing a huge amount of inflammation. Extracellular DNA is very inflammatory. Immune cells know that that either indicates damage or a viral infection, and they will come towards that and amplify their immune response. This is a schematic of the timeline of cell infiltration, and in yellow you'll see the neutrophils come in, and in rodents peak around 24 hours. In people it's a little bit different, but there's millions of neutrophils in the heart within hours of a reperfusion event. But there are ways that the body regulates the immune response. If we didn't have that, we would all be digested by our own immune system. One powerful way is a stem cell type called mesenchymal stem cells. And these cells are found in many tissues, but especially in the bone marrow, where they set up an anti-inflammatory environment for developing immune cells to grow. It would be very bad for your body if the immune cells were activated while they were in the bone marrow. You would digest and kill your bone marrow, and we all know that that would be fatal. The immune modulatory effects of MSCs are very well known. They can inhibit many cell types, including T cells, B cells, and macrophages, and there's some evidence that they may also be able to modulate neutrophils. There's a large, long list of anti-inflammatory and other cytokines that are released by MSCs because their normal mechanism of action is through these paracrine effects. So in using these cells in clinical applications, they're a good candidate because we can obtain them from healthy donors, and they're already acting by a paracrine mechanism. We don't have to do anything to manipulate them to have these sorts of effects. I hate to say that I'm not the first person to realize this, and there's been many clinical trials of MSCs in hyperinflammatory situations, like acute respiratory distress syndrome, SIRS, graft versus host disease, Crohn's disease, and other autoimmune diseases. And the jury is still out on if this is sort of a novel therapeutic strategy. But in terms of inflammation in the heart, in the 90s, there was a lot of strategies that were tried to combat neutrophils. And that's because there were just so many of them in the heart during this initial insult. People thought, oh, if we could only control them, we could really limit the amount of damage after reperfusion. Unfortunately, all of these therapies failed. A lot of them were antibody targeted, where a specific receptor or a specific function of the neutrophil was inhibited. But partially it didn't work because there are so many different receptors listed there where the neutrophils can sense extracellular damage like ATP, mitochondria, proteins, inflamed endothelium, many sorts of things, and blocking just one is unlikely to inhibit the neutrophil response. The other reason why these didn't work is because giving a single dose of an antibody at a single time point is unlikely to kill this immune response. Your bone marrow can make trillions of neutrophils a day, and so a single time point inhibition is not going to be an effective strategy. So what we hypothesized was that mesenchymal stromal cells can reduce early innate immune response, specifically the neutrophils, in ischemia reperfusion. And I was lucky to have a fabulous research fellow, pictured here and present in real life, who was able to conduct some of these experiments, Eric Shin. Our methods are like this. We have rodents and we ligate temporarily the left anterior descending artery. And you can see that those forceps are actually holding a temporary suture in place, causing the ischemia for 30 minutes. On top, you can see a pile of, it's not caviar, but it is encapsulated mesenchymal stem cells that we hold in place over that infarct area with a hydrogel. Next, we use transthoracic echo and strain imaging to quantify the amount of cardiac damage or recovery. And then at whatever time point we want, we digest the heart and extract out the inflammatory cells so that we can count and characterize them using flow cytometry. So we found that in animals treated with the encapsulated mesenchymal stem cells, they had a reduced number of white blood cells within the heart at 24 hours compared to animals that underwent ischemia reperfusion with no treatment. We also looked at the subtypes of cells and found that lymphocytes, neutrophils, and macrophages were all reduced at 24 hours. We also were wondering if some of those detrimental processes of neutrophils were affected, specifically reactive oxygen species. And we were able to measure this both in vitro, where treatment with MSCs reduces reactive oxygen species, hydrogen peroxide, and superoxide in vitro, but also in vivo. In animals treated with our encapsulated MSCs, the hearts had less hydrogen peroxide at 24 hours. Which coincides with our data showing not just are there fewer neutrophils, but they're having less of these toxic and inflammatory mediators. I was also lucky to have a very talented high school student in my lab who helped us characterize some other neutrophil functions that were modulated by MSCs. We can study neutrophil migration under the microscope. These are neutrophils that were isolated from a healthy donor. And when you put a concentration gradient of an inflammatory mediator, they'll crawl towards that, as shown in the top frame here. But in the bottom, those were actually treated with MSCs. And when we quantified the amount of migration, the neutrophils were actually less likely to migrate towards the inflammatory stimuli when they were treated with our encapsulated MSCs in vitro. So we concluded that MSCs reduce this innate inflammatory response, and this may be a new therapeutic strategy to target neutrophils, a cell type that we really sort of ignore in clinical and also basic science research. And this could really reduce the scope of early inflammation, which would then downgrade the size of the inflammatory response at later stages of ischemia reperfusion. Now, that's all well and good, and I spent a little bit of time talking to you about cytokines and how these encapsulated cells can release these cytokines, and maybe that's what's going on. But when we really started to think about that and the timing of that in correlation with the timing of the inflammatory response, that didn't quite mesh up. I estimate it would take at least a couple hours for the MSCs to really upregulate their cytokine production, release these into the heart, have those diffuse through and have these anti-inflammatory effects. And by that time, the inflammatory response was already up and roaring. Maybe there's some other mechanism that's faster that could also be at play. And so we started thinking a little bit about ATP. ATP is the universal currency of energy in all cells. Those three phosphates can be cleaved, releasing energy when the cells need it. And ATP is almost always intracellular. Very rarely should you have ATP just floating around in the extracellular space because cells are stingy and they would never just let it float around out there unused. But in situations of tissue damage, ATP is released, and that is a signal to the immune system that something is wrong. And it's a lot of immune cells actually have specific ATP, ADP, or AMP receptors where they're attracted to this as a sign of tissue damage. These purines, like I said, there's receptors on many cell types, not just inflammatory cells, but they trigger a lot of inflammatory actions of neutrophils, macrophages, and even adaptive immune cells like T cells. MSCs express a molecule called CD73, which is an ectonucleotidase. That's a fancy way of saying that this molecule can convert ATP, ADP, and AMP, which are inflammatory, into adenosine, which is anti-inflammatory. ATP, like I mentioned, is sensed as a damage-associated molecular pattern by many cells of the immune system. But adenosine has many effects that I was actually not aware of. It inhibits neutrophil migration and our reactive oxygen species production. It pushes macrophages towards an anti-inflammatory phenotype. It prevents T cell activation, and it's so anti-inflammatory that some bacteria actually produce adenosine as a way to escape the immune system. And this CD73 is highly expressed by MSCs. It's actually required as the definition of what makes a cell an MSC. But you may know, adenosine is not a stranger to us in cardiology. We give IV adenosine when there's tachycardia because it can cause AV block. It can promote vasodilation, which is why we use adenosine receptor agonists in stress testing. And ATP and ADP sort of have the opposite effects. They can cause vasoconstriction and platelet aggregation. And I just want to mention that coffee, my favorite adenosine receptor agonist, is also, the effects are very well known on how it activates the neurologic system. So adenosine has a problem, though, which is its very short tissue half-life. That's why when we give adenosine to stop or diagnose a tachycardia, we have to give a bolus as fast as we can and an IV as close to the heart as possible. The tissue half-life is somewhere around a second. And because of that, studies of adenosine for treatment of reperfusion or reperfusion injury have really not worked. In animal models, adenosine, which is shown here in the black bars, can reduce infarct size, it can reduce neutrophil infiltration, and it can augment coronary blood flow. But it has to be given by a continuous intracoronary administration, which is just not technically feasible. Not only would that mean a chronic indwelling catheter, but it also causes dose-limiting hypotension, which is why we're not typically giving adenosine for our STEMI patients. That being said, there was a recent clinical trial that tested this and really showed very similar results. Patients were randomized to standard of care reperfusion, adenosine, or nitroprusside. And this trial showed that there was actually no benefit to adenosine and possible harm in patients. It increased infarct size, decreased ejection fraction, and increased MACE at 30 days. I'm not trying to say there's no situation where you should give adenosine, but it's obviously not our standard of care. So we hypothesized that our MSCs, which we know are anti-inflammatory, may be able to produce local tissue levels of adenosine that may give us these anti-inflammatory effects without those systemic hypotensive effects related to just IV adenosine administration. The other benefit of giving this with MSCs is that it's essentially continuously produced over the first couple days when we would really want anti-inflammatory, maybe vasodilatory, and maybe platelet inhibitory effects. First, we tested in vitro if MSCs were able to make adenosine, and we found that yes, they could. MSCs in the second column, just sitting around, don't make any adenosine, but when we give them that precursor AMP, they actually make a lot of adenosine. We utilized a chemical compound called APCP, and that inhibits that ectonucleotidase CD73. When we treated MSCs in vitro with APCP, they really no longer made much adenosine. So Eric then tested our hypothesis in vivo, and we found that in hearts, 24 hours after ischemia reperfusion, animals treated with the encapsulated MSCs had increased adenosine production. But when we blocked it with CD73 with APCP, the tissue adenosine levels no longer were increased. So we knew we could at least, our hypothesis was supported that these MSCs increased tissue adenosine levels. Next, we looked at those white blood cell counts I showed before. And we saw, as I mentioned, that encapsulated MSCs can reduce the number of white blood cells in the heart at 24 hours. But when we pre-treated the MSCs with APCP prior to implant, they were no longer effective at reducing the white blood cell infiltration, suggesting that this mechanism was key to their anti-inflammatory effect. And this was true for all subtypes of white blood cells, neutrophils and macrophage that we looked at. And lastly, we also looked at neutrophil effects, including that hydrogen peroxide. And again, we found that encapsulated MSCs were effective, but if we pre-treated them with APCP, they no longer reduced the hydrogen peroxide in the tissue. And this translated to functional effects. These are the results of the transthoracic echo, global strain, global longitudinal strain rate, and ejection fraction were only improved in animals that were treated with the encapsulated MSCs, and when we inhibited their ability to produce adenosine, they were no longer effective. And we confirmed that this did not change their cytokine production nor the viability of the MSCs. And I'm happy to say that this was accepted last week for publication in the Journal of the American Heart Association. So we were very pleased with these results, but wanted to go a little bit further and look at some sort of interesting and weird activities of neutrophils, and that's how we began to explore NETs, or neutrophil extracellular trap formation. As I mentioned, neutrophils typically have 3 or 4 lobes when you look at them under the microscope, and that's actually because their DNA is wound up so tightly that they can't really make a lot of proteins from those genes. But during netosis, they actually decondense their entire nucleus and expel all 6 feet of DNA into the extracellular space. And as you can see, that can be very inflammatory. On the top is just what neutrophils look like resting, but on the bottom, all the green is essentially expelled DNA. And this process is very dramatic. This is what it looks like under a microscope. It's really like a fireworks explosion that you can see there in those cells. But that's not the whole story with NETs, because if you zoom out, and I've circled where that one individual netting cell is, after that cell makes a net, it's very inflammatory to all of the neutrophils around it and triggers this huge cascade of inflammatory effects. NETs have been implicated in cardiovascular diseases, specifically venous clots. They are well known to be found in deep venous thromboses and pulmonary emboli, but they've also been found in plaques that have been aspirated out of coronary arteries during STEMI. In the picture on the right, you can see all of that red is NETs. And so there's a lot of research going on trying to understand how important is this in the processes that we see every day. We hypothesized that MSCs may be able to regulate NETs, and maybe through their adenosine production. I should mention that currently there are no known endogenous regulators of NETs. There must be some, because very few things in the body are allowed to proceed totally unregulated, but we don't yet know what they are. So in some unpublished work, what we've done is we've treated neutrophils with adenosine, and we were able to see that there was a dose-specific inhibition of NETs in vitro when we treat with adenosine. We also treated NETs, MSCs to make NETs, and then treated them with MSCs, and were able to see a reduction in the amount of NETs in isolated cells treated with MSCs. Eric spent some time working with our flow cytometer, and using a technique called image stream, we can count the cells, but we can also take pictures of them, which helps us confirm that we're measuring what we really think we are. And across each row here is the same cell imaged with different dyes. So the first column is just sort of a bright field of what the cell looks like. And you can see that there are some neutrophils that are beginning to decondense their nucleus. And then as we go down the row, actually decondense, release, and then totally expel their DNA. And we were able to confirm that with these different dyes, that we could count the number of nets by flow cytometry. We then tried this in vivo after ischemia reperfusion injury and found that animals treated with the encapsulated MSCs showed a reduction in net formation. And what we're working on now is seeing if that's also true with APCP-treated MSCs, or if this adenosine production is required for regulation of nets in vivo. But we're continuing this work, and we're hoping to have some results in the future. But we can conclude at this point that encapsulation improves the efficacy of encapsulated MSCs. MSCs are capable of regulating the innate immune response in ischemia reperfusion, and a key mechanism of their action may not just be those cytokines they produce, but actually tilting the purinergic balance away from ATP, which is inflammatory, towards adenosine. And neutrophil extracellular traps may be a key neutrophil activity that they're regulating. We're working now to make MSCs that genetically lack CD73 to more precisely test the effect of this ectotoot nucleotidase. We're working on other techniques to measure nets, and we're working on identifying pathways in the cells that actually regulate netosis. But this may lead to some new therapeutic strategies. Maybe we don't need to deliver MSCs. Maybe we can just deliver bioactive CD73, and we're working towards that as well. But going forward, we're very interested and feel that these biomaterials are essential for translation of stem cells into an effective clinical therapy. But that raises some problems. In rodents, we can cut them open, we can give them a heart attack, we can deliver them a gel, and they don't complain. But in people, very few people actually want to have an open heart surgery. And so it's necessary to think of a way that we can deliver these therapeutics to the heart. Gels are very viscous. And so it may be very dangerous to inject them into the coronary arteries of a patient, especially one that's just had a heart attack. Same goes for intramyocardial delivery, say by a NOGA catheter. If any little dollop of that gel were to embolize, that could lead to a stroke or some other vascular occlusion. On top of that, the capsules are several times larger than capillary, and so if we just put these capsules alone into the coronary arteries, they could very easily cause more clogging. So because of that, we've started wondering, is there another space that we could utilize to deliver therapeutic hydrogels to the heart? And that's when we thought of course, the cardiac epicardium. This is a non-vascular space that is in very close anatomic localization to the heart. The pericardium is fibrous and not very porous and acts to concentrate and focus things within the pericardium onto the heart. Also, this may have less arrhythmogenic risk than inserting a gel into the heart muscle, which could serve as a focus for a reentrant circuit. And luckily, over the past 10 to 20 years, different therapeutic strategies have utilized the pericardial space, such as epicardial ablation, lariat delivery. And so we weren't really, there was some precedent for being able to go into a dry pericardium and do some therapeutic action. So we designed a device to allow the minimally invasive delivery of hydrogels to the heart, and this is a schematic of what it looks like. Essentially, we do a subxiphoid pericardial access procedure using standard fluoroscopy, and the device is placed over the heart and forms a temporary container, essentially, for hydrogel delivery. It sits on top of the heart, as pictured here, and forms essentially a circular fence. The gel is then placed within this circular fence, and the pericardium drapes over top, sort of sealing this temporary compartment. The components of the gel, the cross-linker and the gel material, are delivered into that space where they mix and form the gel at the location we want. We were able to test this device in vivo, and as you can see, it enters, this is the catheter going into the pericardial space, forming this fence-like area where the gel can be delivered. After that, the gel is, the fence is retracted and maintains that circular shape so as not to disturb the gel that we just delivered. We tested this in collaboration with Gautam Kumar, one of our interventionalists, and we could reliably place this delivery device over the left anterior coronary artery, and you may be able to see the pericardium kind of draping over top of the device. We could visualize the gel and the device in vivo, and then also stain the gel with blue dye so we could look at how well we delivered it after explanting the heart. But that being said, our goal is, of course, to use this device to deliver stem cells to the heart. But it's difficult to move that forward because there are no approved stem cell therapies. So what we decided to do was look at some other therapeutics, including amiodarone, to kind of show proof of concept that this could work. Atrial fibrillation, as we all know, is the most common cardiac arrhythmia. It affects the atria of the heart, especially when the heart is damaged by heart failure or some other insult. There's many patients, 10 million in the US, probably an underestimation, and at least 30 million worldwide. And in the US, we're spending about $33 billion a year treating atrial fibrillation. It's chronically increased morbidity and mortality. It has a stroke risk, and patients are often very symptomatic from this, requiring hospitalizations, cardioversions, ablations, and other procedures. There's many medical therapies available, and it's common that our patients spend years kind of going through the pathway of first trying rate control, maybe a cardioversion or two, maybe an antiarrhythmic strategy, maybe an ablation strategy. And after all of that, there's still quite a few patients that are still symptomatic from atrial fibrillation. My last call weekend, there was one day where we admitted 10 patients, and every single one had atrial fibrillation. Amiodarone is old medicine. It was approved in the 80s to treat ventricular arrhythmias, and actually is not indicated for atrial arrhythmias. Of course, it's often used off-label for that. It's hydrophobic, and its main problem is that it can be quite toxic. Amiodarone delivered systemically tends to build up in other organs like the lung, liver, thyroid, fat, and even in the skin when it was first released and people were getting very high doses of amiodarone. At least 50% of patients who take it chronically have some form of toxicity. But you could argue that amiodarone is one of the most effective medications for treating atrial fibrillation. In this trial comparing amiodarone to propafenone and sotalol, it was more effective. There's also a recent Cochrane analysis that shows amiodarone is more effective than all the other antiarrhythmics at maintaining rhythm in atrial fibrillation. So we collaborated with Andres Garcia, who is a mechanical engineer at Georgia Tech, who specializes in engineering gels. And I asked him if he could put hydrophobic amiodarone into a hydrogel. And he said that he thought he maybe could, and he would try. And luckily, he was successful. Our goal was to create a gel that would release amiodarone over several months. The idea would be that patients with refractory atrial fibrillation would come in and get a amiodarone gel delivered to the area of the left atrium, and that would sustain drug release for several months. We first tested in vitro if this was working, and we found that we could achieve several days of release in vitro of a small gel. We then went forward and tested whether or not the gel released amiodarone over time in a small animal model. We obtained a special syringe that would allow us to gently puncture the pericardium in a rat and then deliver a gel to the heart. The rats were not in atrial fibrillation, but we used this more so to test the distribution of the drug in the hearts. The rat's heart rate did not change, which was a good indicator that they weren't getting tamponade from this procedure. The graph at the bottom shows the distribution of amiodarone in two groups of rats. The black bars are rats that got systemic amiodarone once a day for a month by intraperitoneal injection. And the red bars are rats that got a one-time delivery of the amiodarone-releasing gel. As you can see, the systemically treated rats had a large accumulation of amiodarone in off-target organs, in some cases 40 times higher than the drug levels in animals that were treated with our gel strategy. Also, after 28 days, there was still quite a bit of amiodarone in the gel that hadn't yet been released, showing that we had at least achieved 28 days of extended delivery. We then next looked to see how much amiodarone was actually in the heart. And in animals treated with the daily intraperitoneal dosing, there was amiodarone also in the heart, but again, it was many orders of magnitude lower than what it was in other off-target organs. The gel also achieved detectable drug levels, but they were lower than the animals that received the daily dosing. One challenge with researching amiodarone is that nobody knows what drug concentrations in the heart are necessary for efficacy. There really have not been any studies, and definitely not in atrial arrhythmias, that have been able to show that. Autopsy studies of patients who have been receiving chronic amiodarone show levels somewhere in the 5 to 100 micrograms per gram range are what patients have if they either have a heart transplant or die while on the drug. So it wasn't enough to show that we could deliver amiodarone with our gel. We really wanted to show that it was effective. And for this, I collaborated with Jonathan Langberg, one of the electrophysiologists at Emory. We had to make a large animal model of AFib, and we did this by overdrive pacing the atria of the heart in a large animal. Overdrive pacing at a rate of about 600 is an accepted animal model of AFib, but typically people do this with a neurostimulator, which is very similar to a pacemaker, except it will let you program a rate of 600. The problem with using neurostimulators is that it only gives the electrical stimulation in one focus. It also has to be transcutaneously charged on a weekly basis. The battery does not last, and that is a problem in a large animal model that won't, let you attach something around its neck to charge its neurostimulator. So what we did was we took a chronic resynchronization therapy pacemaker, and instead of putting the leads in the atria ventricle, right ventricle and left ventricle, we implanted all of the leads into the right atrial of the heart, and we're able to come up with a similar rate, but even better, it was a little bit disorganized, more closely mimicking the clinical condition of atrial fibrillation. The other benefits of this was that we did not have to charge it, and we could do EP studies, non-invasive EP studies on a weekly basis on these animals, and that's what we did in 8 pigs. 4 of these pigs were treated with a control gel that had no amiodarone, and 4 were treated with the amiodarone-releasing gel, and we were analyzing them on the same methods. So we were happy to see that we were able to induce atrial fibrillation as detectable in the intracardiac recordings from the CRTPs, but also by 12-lead EKGs. The main findings were that when we turned off the CRTP pacing, we measured the time until the animals converted back into normal sinus rhythm. The blue animals that got the control gel stayed in AFib longer than the animals that received the amiodarone releasing gel when we got out to 20 and 28 days, showing that our gel was having an effect at 28 days. Another electrophysiologic test that we did was we gave them 50 hertz pacing to see how likely they were to be induced into atrial fibrillation from sinus rhythm. And again, we were able to see at 14 and 21 days that our gel was effective. At 28 days, we did not meet statistical significance, partially because one animal in the control group had less inducibility at that time point than it had at earlier time points. And that's just a factor of this being a small study with 4 animals in each group. But I do want to point out that the amiodarone gel only had 50 milligrams of amiodarone in it. And so we were able to achieve effects 1 month out with this small dose, which we all know is a fraction of the dose that we give people on a daily basis. We also checked carefully for toxicity, and we did not see any change in atrial fibrosis, either treating with an empty gel or with the amiodarone releasing gel. We also were concerned about triggering pericardial inflammation, which could be a very big problem clinically, leading to constriction and other pathology. On the initial trials, we didn't treat the animals with any anti-inflammatory agents, and they developed pericardial inflammation. But after giving colchicine and 1 dose of intrapericardial steroids, we were able to completely mitigate any pericardial inflammation on a histologic level. We confirmed this with invasive hemodynamic measures by right heart cath, as well as pressure measurements, and we found there was no change in right atrial pressure, right ventricular pressures, left ventricular end diastolic pressures, wedge pressure. Everything remained stable over the acute gel delivery, which is the first 2 lines, and then after 4 to 6 weeks after gel delivery. So in conclusion, we felt that epicardial gel delivery was safe, and this would be feasible with our technique because it can be done in a cath lab procedure lasting less than 30 minutes. Traditional therapeutics like amiodarone could be delivered in this way, but also maybe more modern therapies like stem cells, microRNAs, viral treatments for different cardiomyopathies that are in clinical trial now. This may be a more efficient way to give them directly to the heart and avoid systemic dilution or systemic off-target effects. And this would circumvent a lot of the dangers with intravascular delivery of gels. Future studies, if we get funding, we hope will allow us to do larger and longer studies to really see if this is a translatable therapy. We're also working on other therapeutic hydrogels, and then hopefully we'll test our MSCs, encapsulated MSCs, in a large animal model. So in summary, I've talked about a wide range of topics, but the way I see it, it's 3 main areas. We can target neutrophils with new tools and at the same time achieve a deeper understanding of how they are pathologic. We can utilize biocompatible materials to make stem cell therapies more effective and also gain a better understanding of how these MSCs are working. We can also find safer ways to utilize old medications and at the same time new ways to deliver new therapies to the heart. And I would like to just end by thanking many people who have participated in all of these projects, especially my lab. I've pointed out the work that Eric has done. Dr. Taylor, a lot of the work I started was in his lab, and he's also given me invaluable advice on many aspects of this work. Our collaborators at Emory and Georgia Tech, and especially many clinicians have really helped, especially with the translational work. I put Dr. Langberg and Mike Hoskins on here, but I think I've talked to maybe every single one of our electrophysiologists at some point and asked them what they thought. I've spoken with many of our interventionalists too to get their perspective on, how realistic is this. And we've been very lucky to be funded by American Heart Association, the Georgia Research Alliance, Coulter Foundation, and the Aronoff Foundation. And I'm very hopeful that they will continue to support our work. So thank you.
All right, we're open for questions. I won't ask you one. Who has some questions from the crowd? Andy has a question.
Rebecca, this idea that ATP generates an immune response, does that, as I think about our patients with heart failure who have chronically elevated troponins, would that be related in some ways? Do those patients with chronically elevated troponins have more of an inflammatory response in the heart?
Yes, it's definitely thought that and it's not just the troponin, but exactly like you're implying, the cell death that may be occurring in kind of a diffuse level is thought to trigger inflammatory response. Probably not as robust as we would see in an acute incident like myocarditis or ischemia reperfusion, but it's thought that the chronic inflammation, the innate and adaptive immune cells can really trigger a lot of that chronic fibrosis too that's seen. Amyloid also is very inflammatory, and so that also has an immune component. There's even some people who think essentially every cardiac disease and potentially every disease ultimately has some root in inflammation.
So what clinical situations do you think you could use sort of epicardial delivered amio? Because probably not for everyone, right?
No, it is definitely not for everyone. This is an invasive procedure that I think would really be ideal for those patients that have gone down that pathway. They've tried, different antiarrhythmics. They aren't candidates for many of them due to heart failure or coronary disease. They have maybe had an ablation and went into some sort of, they did not maintain their normal sinus rhythm, and they're having symptoms from it. We all know that rate control is potentially equivalent or better to rhythm control, but one issue with those studies is that we really were not able to achieve rhythm control in many patients. So this is really a therapy that should be done or could be done in those sort of refractory patients with symptoms coming in again and again with heart failure. And once we know really the long-term effects of it, it could potentially be for other patients, but starting off, definitely those more refractory patients.
Rebecca, why not pick the post-open heart patients with atrial fibrillation? I mean, you have easy access to the heart, and you have an arrhythmia that's very common and problematic.
Which
Particular
patients?
just open heart
Oh,
patients
yeah.
to look at,
Yeah.
particularly if you could deliver the gel localized along the posterior wall of the left atrium. You might, if the surgeons can access that, that might be a model in which you can test it pretty readily.
Yeah, absolutely. There's actually one practical reason why that is not, two practical reasons. The first is that the gel adheres better with the pericardium intact. So there may be some open heart patients that don't have that, but some will. The other issue is that the reality is that we need intellectual property, and the only intellectual property is on the delivery device. And so we potentially would have to develop it as a drug-device combination. And of course, you could utilize the gel however you wanted once it was in clinical use. But to pay for the cost of development, we're going with these sort of non-open heart surgery patients. There are also other gels, amiodarone releasing gels that last for about a week. One is in clinical trial. The difference is that it is actually more inflammatory, and it requires like a spray gun essentially to apply it. And so that particular gel cannot be used in this minimally invasive approach.
But if you limit yourself to the area that I described where the pericardium is not moved away, I mean, if they could apply it and you can somehow maintain the gel just in the back wall of the atrium. I realize it doesn't address your intellectual property issues, but it may address the issue of determining whether or not local delivery might be helpful.
Yeah, absolutely.
So I was just curious what other drugs you think could be potentially delivered in this using this mechanism?
I actually think that there aren't that many drugs. And the reason is there's very few drugs that are as toxic to other organs as amiodarone, which is why we chose it. I think that this gel would be much more beneficial to these newer therapeutics that work in a totally different way than drugs. And like stem cells are the classic example. We've been injecting stem cells. We know they don't stay in the heart, yet we keep doing it and hoping something different will happen. Another interesting one is viral vectors, gene therapy. And a lot of us know that there was a lot of excitement over gene therapy 10 years ago, and there were some tragic cases where patients died from this, overwhelming immune reaction, and that field has advanced quite a bit. There's new viruses that have much less inflammation, and there's been some clinical trials for heart failure for SERCA2A and other genes that may modulate myocardial calcium, which is disrupted in heart failure. That clinical trial did not succeed because, one, patients had antibodies against these viral vectors, and also because very few cardiomyocytes were transduced by the vector. So that may be an ideal therapeutic that has actually shown some safety, and maybe if we deliver it in this different way, we'll have better transduction and better efficacy. The other thing is, I don't know if anyone in the back row wants a gene therapy for atrial fibrillation. It's hard to deliver viruses to the atria of the heart. It's hard to select a coronary artery that would just go to the atria, and you can't inject a needle very easily into the atria because the wall is so thin. So since we can quite easily go posterior from our subxiphoid approach, we could potentially use this gel to deliver some gene therapies to the atria.
Just curious, like this hydrogen, the encapsulate or hydrogen, how long after they inject in the body, how long they will become degenerative or degrade?
We can engineer that per our application. So the gel that Eric used was engineered to be degraded in about a week to 10 days. And that can be, that materials has been tested in many kind of situations with delicate cells like pancreatic islets and things like that. The gel that we used in the pig study was quote unquote non-degradable. And so it should last, it has the potential to last for many weeks. So we can really engineer that, and that's the benefit of working with our engineers at Georgia Tech.
Well, thanks very much, Rebecca, for a fantastic talk.
The preceding program is copyrighted by Emory University.